Hi, I'm Dr. Jason Wagner with Sarasota Vascular Specialists, and thank you for joining me for a Whiteboard Wednesday discussion on Steele syndrome and the dialysis access circuit. Just to catch up to speed, a hemodialysis fistula or graft is a connection between an artery and a vein. We have either the vein sewn onto the artery, as shown here, or we have a graft, an artificial vein that connects to the artery somewhere in the arm, to higher up in the arm, to the vein side. Blood flow is going from the artery, from the heart, high pressure, high resistance, ideally going all the way to your hand. But when we make that connection to go to the fistula to the graft so you can have good flow for them to pull off, blood and send it back to you with dialysis, we're always stealing a little bit of blood flow from the hand. A little bit is fine. Too much, not so good. If the connection is too big here, or if for some reason not enough flow is getting to the hand, the symptoms of that are going to be hand pain, sometimes with dialysis or sometimes just at rest. Good preoperative testing by a certified lab and by board-certified vascular surgeons is going to help limit or minimize that risk. If you do find yourself with hand pain with dialysis, or you have hand pain with a dialysis access fistula or graft in the upper arm, there are things we can do to evaluate that and to treat that. So the first thing we need to do is figure out how much blood flow is going through your fistula or through your graft. Is blood going smoothly from the heart all the way down towards the hand? And where's the problem? If the problem is something closer to the heart or in the inflow part of the arm, we would treat that usually either from the groin or from the arm, coming in and opening up that blockage or issue. If the issue is beyond the connection between the artery and the vein, closer towards the hand, we would also treat that using ideally a minimally invasive way. If the arteries are all fine and it's just simply that the connection is too big between the artery and the vein, there's something called banding, where we can actually make a small incision around here and we actually narrow down the vein to create a smaller connection, so you have less flow going through the vein or the graft, and you help improve flow going towards the hand. If it's a fistula, there are things we can do called a distal revascularization and interval ligation, a DRIL, and that's where we actually make a little bypass higher up in the artery to lower down in the artery, and we get rid of that connection so the hand gets its own blood supply and the fistula gets its own blood supply. That's a slightly bigger operation. Alternatively, if it's an arteriovenous graft, if you just have a prosthetic graft in your arm, we would not do a drill. And rather what we would do is we would just take your straight graft, which is a high flow, low resistance circuit, and we would double the length of it by having a new graft part that goes further down, turning this into a loop graft instead of a straight graft. By having a longer conduit or longer circuit, it provides slightly more resistance to the dialysis circuit, allowing more blood flow to keep going down towards the hand. That's called a proximalization of arterial inflow, a PAI. So for a graft, we'll usually do a proximalization procedure where it's a same-day procedure. We do it in a hospital setting. Small little incision in the upper arm connected to the old graft at the inflow, shut off the old graft towards the artery and provide better flow to the hand and still keeping your access open. Because no matter what we do, our ultimate goal is to get better blood flow to your hand and to make it so that we're not interrupting your ability to get dialysis through your fistula or through your graft in your arm. If we're doing a drill, that's a slightly bigger procedure. Usually you spend one night in the hospital with us afterwards for that procedure. That's a relatively rare procedure. The banding, we do same-day surgery center or at the hospital, and that's very quick and easy, and that's without any interruption to using your arm for dialysis. All of the procedures we do as far as angiograms or fistulograms or getting in with a wire and catheter and trying to open up a blockage or see what the blood flow is, that's all done either in a procedure center or at the hospital, and that's a same-day procedure where you come and go same day. Ultimately, and in summary, our goal is, if you have Steele syndrome, is to evaluate you, see how much blood flow is going to your hand at rest, how much blood flow improves, if any, with compression of your dialysis fistula or a graft. And then we go down an algorithm that is very well codified to make sure that we figure out what's causing the problem and then fixing it as quickly and efficiently as possible without interrupting your ability to get dialysis. Again, I'm Dr. Jason Wagner with Sarasota Vascular Specialists, and thank you for joining me for Whiteboard Wednesday.
Thank you.